определенные зоны, это визуальная кора, соматосенсорная, слуховая и так далее, которые обеспечивают специфическую высшие функции. Но, с другой стороны, соответствует ли это действительно?
It is like that. When we are talking about being awake, yes, sure. But Ivan was also studying for a long time the eyesight, making experiments on cats and and other animals, and he's been doing that for 30 years, and the cats would be sitting here and she would just sleep for a while, fall asleep, and sometimes the cats can sleep up to 12 hours, and of course that was practically impossible to keep her awake, and the neurons of are different in the cortex, and the same neurons, the neurons of the visual cortex, they also respond to stimulation, and that was the effect of specific optical cortex, and also there was electric stimulation of intestine. Of course, brain cannot be still, so because sleep is an active condition, if the neurons do not have information, so the neurons will die quickly. And also the workload should be comparable to awakening condition, so the brain should get information non-stop. But what kind of information during sleep? He demonstrated that not only visual optic cortex but somatosensorial. So A is the first one, and the second is motosensorial, B, and also there is a response of neurons to stimulation of GIT. And the next experiments proved more and more his position that there are specific cortex zones which process information of internal organs during sleep. That was demonstrated not only for GIT but for heart as well. We see ECG interference, and these are not artifacts related to stimulation of GIT or heart beating. And he did that not only with the encephalogram, but that was assessment of activity of separate neutrons. So the bipolar electrodes would be introduced into specific neurons, and also it was demonstrated in the encephalogram and for the respiratory system. So respiratory fluctuations and corresponding changes in neuron activity during sleep. And after that, he had experiments with monkeys, and he demonstrated that there is a medial potential in response to intraperitoneal electrostimulation, which was in the optic cortex in two types of monkeys. So it's in different types of animals, which he demonstrated. That is the scheme, how he explained awakening and sleep. When you're awake, there is transmission of information from outside environment through the receptors, tactile, sensory, and visual. So it gets to the cortex, processed, and we need to interact with the environment, outer space. So this is our main means of adaptation, and he just portrayed it like this, but this is the work of neurons which can be turned on and off, and also there are regulatory neurons here. It is demonstrated like that with violet sign, and then it provides for our motor activity and during being awake, we are talking about cortex. The information from the visceral system is blocked from the autonomous nervous system, but also there is associative visceral regulation, which we see here, like stop sign, and this is the system which we do not know where it is located, but we see that maybe this is around hypothalamus, and during sleep we may see that the situation changes here. The information from extra receptors does not get to cortex practically. Our conscious is off. Motor activity during healthy sleep is absent, and the information from internal organs, from interoreceptors through autonomous nervous system goes to the cortex, brain cortex, and through associative regulation provides for the rehabilitation and restoration mechanism that is provided by a healthy sleep. We understand all perfectly if we just deprive of sleep, any living being will die in a week. And also there are no fatal cardiac events, and there are no cancer diseases, no cardiac arrest, but the body just dies in a week. And slow sleep, this is the cortex control of information coming from visceral organs with a pronounced rhythmal activity. The first place, this is GIT, heart, and lungs. How this information gets to the cortex? There are two pathways, and he studied that in his recent years, and of course we may see the well-known structure of the nervous system. The two main pathways is parasympathetic, sympathetic through vagus and the bone marrow, and also he was a real scientist and he understood the clinical implications, and he will tell his pupils about the Zacharian Guide zones and how many organs are represented on skin, and why it is very important in terms of transmission of information. And this convergence, somatovisceral convergence, may happen at all levels of a spinal cortical pathway, and that's why for myocardial infarction you have the feelings in the lower jaws, in the mandible area, in the hand, in the arm, and in the heart, but it should use the same tissues. If it's happening during awakening, it's one story. If it happens during the sleep, then the same fibers should be used for transmission of information from internal organs. Somatosensory information is transmitted from the pathway of marrow during awakening, and visceral information is transmitted only during sleep. For that, he conducted experiment, and he also implanted electrodes, but on top of encephalogram, he also did the diagnostic of the marrow. So the electrode was on the bone marrow, and he studied what was happening when the rabbit was falling asleep. What he saw. We see the encephalogram of awakening. In red, we see falling asleep, and we cannot see here a significant difference. The amplitude is increasing, and if we will look in a broader scale, we are going to see that this is a classical EEG of slow sleep, non-REM, with the delta waves and so on. And we see the data of the bone marrow. We may see that before falling asleep, there is pulsation, which is somatosensory transmission of information from muscles, from receptors, and another external information. And during falling asleep, this information is blocked, and all of these impulses, they practically go down to zero. But after a while, after several dozens of seconds, there is one interesting thing happening, and there is increase of pulsation in the same fibers, which was the transition of somatosensory information. And there is pulsation, growing pulsation. So the rabbit is asleep. He does not perceive the information from outside, and the amplitude is increasing of transmission in these nerve fibers, nerve filament. And this is one of the experiments which proves that during sleep, the same filament, the same fibers, which are used during awakening time for some of the sensory transmission. So at the same time, during sleep, the internal organs transmit information through these fibers. And we do not understand this algorithm, this mechanism. It's still too complicated. When we discussed that with Ivan, and he said that we will decipher this information not in the nearest future even, but if we get close to analysis of this information, if we are just able or to interfere for treatment, then we'll have a unique tool for a diagnostic of many internal diseases, and probably just to treat those diseases. So here in my brief review, I tried to just explain the theory of Ivan Pigarov about the functional usage, functional properties of sleep. If you would like to just learn the details, you may find his publications in leading and Russian magazines, international magazines, and also you could watch his lectures on YouTube. And also the role of sleep is not clear completely to us, because there are lots of different theories and hypotheses about the functions of sleep, such as synaptic homeostasis. During sleep, it is believed that there are changes in the homeostasis. There is change in synaptic connection between neurons. One of the connections are eliminated, others just are strengthened. And consolidation of memory theory, we know that during sleep there is memory consolidation process. It gets from temporary to permanent. Repairment of DNA, it's one of the theories of functional properties of sleep, and genome is working differently during awakening time. And also, if we have impairment of sleep due to different reasons, it can be deprivation of sleep. We know that over the past 100 years, the average length decreased from 8 hours to 6 hours, and in some megalopolises it is less than 6 hours. And also we have chronic insomnia, sleep apnea, and this is not changing only our social interaction, our mood, our work properties. It also causes changes in genome. Sleep disorder very quickly during a couple of days may trigger changes in the genome. When we are talking about treatment of internal diseases, in the first place, we should take into account patient condition during sleep. And I would like the doctors of all therapeutic specialties to be very careful with their patients, so that they take that into account this aspect in their clinical practice. Thank you for your attention. And the first part is over. As far as I understand, we may have questions. You may write them in the chat. If there are questions, I will answer them. And now we have our next topic, which is the following. And we will speak about iron exchange and sleep disorders. So we have quite an interesting results. Professor Del Rosa from the US, she works in Seattle in the state of Washington, and she deals with the pediatric sleep disorders. In her presentation, she will speak about their studies, and also she will present their results. So my name is Lourdes Del Rosa. I work in Seattle in Washington. I'm very happy to be at this forum about sleep. Today I'm going to tell you about this new disorder. Restless sleep disorder in children. I'm going to speak how we can identify and characterize this new syndrome. I do not have conflicts of interest. So to identify the I'm going to make a review and make the differential diagnosis between the primary and secondary syndrome of restless disorder. So how we can just describe the restless sleep disorder in children. Many years ago, when I was a somnologist and a pediatrician, so families would come and they would complain about restless sleep in children. The kid, he would just move too much and then he would fall from the bed, and parents would say that this child is just moving around and jumping, and it seems to them that he's not just having rest during the sleep, and children were feeling sleepy, and they had bad behavior. They had issues with the academical studies as well. So what we did in our first research publication here, we compared children who contacted the clinic with the restless sleep, restless legs, and the control group. And a leg discomfort to move and restless sleep. Here we have the same symptoms during the day. If children, they have issues with the sleepiness, they have cognitive behavioral disorders and hyperactivity, and also restless leg syndrome. Children, they had this in the family history, and also such children have more movements, more amplitude during the night, and the control group did not have such symptoms. And the difference is in yellow. We did a story of sleep for all children who contacted us for restless sleep in the control group. This is a pilot study for restless sleep. What we see here, children with restless sleep disorder and children with RLS, the restless leg syndrome, we see in blue the same symptoms, the correlating symptoms. Wakefulness and efficacy. We are not talking about insomnia, so they could fall asleep properly. What we can see here, children could not just do that because they slept less, because their movements would interfere them and will not enable them to sleep enough, and they had more awakening during hours. And we also started the movements of the legs, and we found out that the children with restless leg syndrome, they were moving more compared to restless sleep disorder, and they had no so many movements of legs, like in the control group. We see that this is not insomnia, this is not the insomnia. And based on this information, we realized that was a different disease. So we can watch the video. This is one of our patient. He has the restless sleep. We do the sonography. So the child is actually sleeping. He's moving a lot. His body changes its position. The child is moving, lots of movements. He changes his position, even despite the fact that he's sleeping. And we can find this video also in the publication. It is to the left on the screen. This is the characteristic of video polysomnography. And also on the second paper, we analyzed the video from polysomnography in children with restless sleep disorder. And also we classify the movements, upper limbs, whole limbs, isolated arm movements, body movements, and we also calculate the length of such movements. And you see that we can see the diagnostic criteria in the publications, beginning of the movement and its end, and the movement in PCG. So it's 7 seconds. I mean, then you see the video polysomnography and the story of sleep. And this is for one of our patients, and the child does not awake. And he's not getting awake. And you see that the movement is very wide. And so this is the video analysis of the movements. And we identify that in RLS, in RSD, they had 7 moves per hour, and RLS, they had 2.8, and that was true for all of the phases, including the phases of non-REM and REM. And also, we saw that the children were really moving a lot during the night. And the parents would complain that the child would move around during the whole night, irrespective when just parents would enter the room and the child would change their body position or move around. And we demonstrated in polysomnography, it was proved that every hour during the night the child was moving, and we may see there were less movements, and because maybe they were not just sleeping, and they would fall asleep by 10, not 9. And also the index of body movement. And the body index movement in the lower limbs, we can identify the control group and RSD. This is the important diagnostic criteria. And for this publication, this is the international group. This is the consensus diagnostic criteria for pediatric sleep disorders. So these are experts on somnology and pediatric doctors. And they developed the consensus diagnostic criteria for a newly defined pediatric sleep disorder, RSD. And here we may see the names of those scientists. And you may see that in English. And also here we may see there are some complaints from the child, from the parents. He has a big range of movements, changes of position of the body during night and whole body. And also it's happening when they sleep. And also they need to calculate the number of movements. And This is a chronic condition 3 times a week during 3 months. And the syndrome of restless sleep may also occur from time to time. And we need to take into account all of the data and take into account whether the child has some medical conditions or other conditions or maybe consequences of drug treatment. So we do not come up with this diagnosis of RSDA, so he needs to meet all of the diagnostic criteria. And also there are additional peculiarities and characteristics which may speak about the RSD large body movement during sleep. Also, these children do not have issues with going to sleep. They fall asleep well because they get tired during the day. Another question, how to code a restless sleep disorder? What do we usually use? And there is no separate code, and the international classification uses the other sleep disorders code. And also we did further studies to analyze prevalence of RSD in our center. 7.7% of children who contacted our center for sleep diagnosis had restless sleep. And this is less compared to RLS, restless leg syndrome, which is around 10%. But there are more such children compared to insomnia children. So this is a widely spread condition. We need to make the studies of the general population, for example, at schools. And also there was the literature reviewed. We tried to analyze whether the syndrome was described before. And we did a systematic review of literature. And also we came up with the criteria, and it had 107 publications in systematic review. And also the literature did not have a clear definition of restless sleep. And we saw that very frequently it is used in questionnaires and also in some questions. And when sleep issues are described, and also then this condition such as obstructive sleep apnea, which is quite frequent. This is not Lester's sleep disorder. This is secondary disease. And also we need to exclude other diseases which may also trigger sleep disorder. It includes deviations of respiratory conditions, so bruxism of sleep and sleep apnea. And also it is very important to take into account all of the criteria, and we came up with a suggested evaluation algorithm from our systematic review, and we recommend to analyze. And we need to analyze certain indications. We need to analyze the secondary reasons. If there were no secondary causes identified, we recommend to do polysomnography to understand whether the child complies and matches the criteria for this syndrome. And in our first study, we realized that children with the restless sleep disorder have low ferritin level. The low iron level, we see that it resembles the restless leg syndrome. And look at this table. And the ferritin level is 16 for RSD children, and we split the children into groups. One group, children were taking iron supplements or intravenous iron. This is the scale of ferritin. So we may see that children have iron deficit, iron deficiency. After introduction of iron, they improved, and you see here CGI improvement and iron. They were taking supplements, so that was intravenous or oral ferrous sulfate, and we saw improvement. They were taking intravenous iron. And what are the prospects and future directions and the current findings? We will continue our findings and our studies. We'll try to come up with the main characteristic. We will also specify the pathophysiology of RSD. I will speak briefly about the mechanisms such as sleep instability, increased sympathetic activation, abnormal cholinergic way, and probably there are other mechanisms as well. And we started another publication about children with restless sleep disorder. This is the sleep pattern, Cpap pattern. It was demonstrated that in RSD children, they have another SAP pattern, and also we see instability of sleep in these children at this level. And we checked several indexes, and we saw some difference and deviations, and there is also significant difference which can be a marker for sleep instability in such children. And here you also see the literature review and the results of this review. This is the Cpap in RSD, RLS, and in control group, which are healthy children. The next study, here we saw the variability of heart rate, and we decided to look for symptoms. And in accordance with this study, we see that there is certain difference in heart rate variability. Yes, it is in fact present, the heart rate variability. Here you may see the heart rate variability, the frequency domain cycle in these populations. Once again, we see the same. You may find such tables in the publications, and we see the difference in between control group and RSD children, and also the cause of iron deficiency. And you see the mean level. In the group of RSD, it's lower compared to RLS, restless leg syndrome. You may also see the ferritin level after ferrum sulfate. You may see that in the table. Future directions of our work. In the first place, we have to assess body movements. We need a unified system for that. Also, we need to assess the symptoms during the day, and also assess the general population prevalence and the prevalence in other populations as well. And present, we are assessing the movements. And this is a scientific work, and there are specific recommendations on how the movements can be identified and how it can be assessed. And there is another publication, it's been just discussed, and this sleep spindles in children with restless sleep disorder are reviewed and analyzed. And this question and this aspect is assessed for other population, and we need more studies to understand this, and also we do a sleep assessment in a specific population, and also these results were published. That is a study of attention deficit and hyperactivity children, and also 81% of parents say that they have restless sleep, and though 75% of such children have comorbidities, which may explain that presence of restless sleep. So there are some comorbidities you may see, the comorbidities which may be the causes of restless sleep in children with ADHD, and we still see that restless sleep in this population is more frequent compared to general population, and also we have the algorithm to assess our attention with attention deficit and hyperactivity, and it's very similar to what we described earlier. You need to do polysomnography and verify presence of obstructive sleep apnea. And to finish, I would like to say the following. There was a great pleasure to share the results of our work with you on restless sleep disorder. It is always very important to find all of those symptoms for successful treatment so that we can help as much children as we can. And also we need to make video analysis polysomnography for the diagnosis. And also in such children, there is increase in sympathetic activity and instability of non-REM sleep, and also mask and other secondary causes should be excluded, and they have subjective improvements of their condition after taking iron supplements. Thank you for inviting me to this wonderful forum. Thank you. I would like to thank Professor Del Rosa for great data for her presentation, because now this information can be used in clinical practice. It is used also for chronic heart insufficiency patients, and also it is used for iron deficiency and iron deficiency anemia. And also we speak about iron deficiency condition, which may be not anemia, and it is more dangerous because this is a latent deficiency of iron, and it is not easy to find. And I would like to draw your attention to this topic, and just it is also very important for any disease group. I would like to give floor to MD, head of sleep lab of Almazov Center from St. Petersburg. Yuri Sviryaev, you have the floor. Thank you very much. Can you hear me? Yes, thank you. I would like to once again thank the organizers, the organizational committee of Eurasian Congress, and Alexander in person for the invitation. Today I'm going to speak about resistant hypertension and a syndrome of obstructive sleep apnea. And I would like to start from the following. Resistance to treatment or resistant arterial hypertension is condition when there are excluded reasons of subjective hypertension, and all secondary factors are excluded. They comply with the life factors, they have adherence to treatment, and also they take 2 or 3 drugs and blockers of renin angiotensin. So this is calcium antagonist and diuretics, and they are taken in optimal dosages, which does not decrease the less than 140 and 90 for systolic and systolic pressure. And this inadequacy of control for arterial hypertension could be also confirmed with the home control, and the general resistance is only 11-13%. And in the beginning of the 21st century, 4 big blocks were identified, those who may trigger. This is pseudo-resistance related to changes, the effect of the white coat and lifestyle factors, and also secondary reasons, secondary causes, which together with diabetes, stenosis of the kidney arteries, parenchymal disease of kidneys, Cushing's syndrome, pheochromocytoma, primary aldosteronism. Also, the authors was attributed to this, and this is what I'm going to speak about in my presentation. Well, I should say that as for these 4 big sections which lead to resistance to therapy, the Russian Cardiological Society also identified changes and adherence to changes in lifestyle, and also obstructive sleep apnea syndrome falls in this category. And if we take into account prevalence of causes of resistant arterial hypertension, and well, the O says this is the most frequent reason, and it is more frequent than essential AH. And between the obstructive sleep apnea and the prevalence of arterial hypertension, there is direct correlation. The prevalence of arterial hypertension is growing with the growing severity of obstructive sleep apnea. And the mechanism is quite simple: activation of a sympathetic nervous system, which is activated in response to apnea, and it is also proved with microneurography, and you may see the episodes in ECG of bradycardia, tachycardia, and also we have 2 types of cardiovascular consequences of apnea, sleep apnea: acute and chronic. And the first is hypoxia, reoxygenations, and hypercapnia, which is consistent periodic hyperactivation of parasympathetic nervous system, and chronic is the consistent hyperactivation of the sympathetic nervous system, which increases pulmonary and systemic arterial pressure and causes metabolic changes, which are pro-atherogenic and pro-thrombotic condition. Later on, it triggers remodulation of heart and vessels, and finally, complications related to ischemic tissues infarction, or there are other peculiarities which speak about resistance of arterial hypertension and sleep apnea. So the night, you may see at the night picker profile, there is no decrease of arterial hypertension, or it can be also increased. And so these are the results of 15 years prospective study with the 4 cohorts of patients with different profiles, and there is no decrease at night, and its night peak is combined with the worse survival in these groups of patients. And what is more prominent here, if we look at the second curve, this is this one, we may see that the absence of dipping at night with hypertension has a worse prognosis compared to arterial hypertension, but with a preserved profile which is maintained during the day. And it was demonstrated that patients with genuine resistant arterial hypertension, despite having less numbers in hypertension compared to patients who are afraid of doctors. So here they have better results, and the same changes were found in the guidelines of the Russian society, which are Society of Cardiovascular Society. So in case of OSAS, especially, it's severe with the index of apnoea more than 30 equal to 30, activates the CNS, and it happens also during the night. Absence of decrease at night, and hypertension at night is worsening by 3.8%. The outcomes for patients compared to patients who had no obstructive sleep apnea. And another North American study, the prevalence of deviations of daily profile of age was more frequent in sleep apnea patients. So talking about that, we need to come to the following conclusion. We need to start treating those patients. And of course, this correlation between these two conditions, of course, medication treatment has been done for years for arterial hypertensions, and the doctors try to assess how angiotensin therapy ACE can be having an additive effect, a polytropic effect on severity of obstructive sleep apnea. And I have here the meta-analysis of 15 studies which used different medications and their combinations, and only in one case, the combination of furosemide and spironolactone demonstrated really efficient decrease of apnea, hypopnea during sleep index. But the rest drugs did not have such a result. A combination furosemide and spironolactone in the guidelines on treatment of resistant arterial hypertension. The second one is the spironolactone, is the one which is recommended to be used for these three groups of drugs used as optimal therapeutic dosage. Also, I would like to speak about the results of the study which was recently published. The use of ablation of sympathetic kidney ganglia. It was called Simplicity Hypertension 3. So the number 3 means that there were 2 previous studies, and take into account experience and disadvantages of previous studies, the researchers assessed efficacy of innervation of kidney vessels with the help of ablation. And in this study, for the first time, they assessed for 2 weeks the genuinity of resistance of arterial hypertension, which was proved with the compliance and also that they have inadequate control with the help of office measurements and 24-hour monitoring that was done during 2 weeks. Angiography was done, and they were randomized on the table practically, and it was blinded. Nobody knew what kind of intervention was done for the patient, as the catheter was used for all of the patients who participated in the trial, in the study, but the ablation was not done to all of the patients, and unblinding and uncovering of the cause was 6 months after, and the patient has to come twice to the center to assess the efficacy and safety of treatment. And the primary and initial and endpoint and final endpoint were assessed. That was aimed at 2 groups of patients with obstructive sleep apnea and patients without OSA, non-OSA, and OSA, and the comparison was done between the real intervention and placebo. And according to the studies, the decrease in these groups were seen only, well, in these groups. Unfortunately, they presented the data only for systolic, and also, as for these indicators, the office numbers for OSA decreased more and significantly more. And in the genuine surgery group compared to placebo intervention, and there were no other differences, neither in OSA, neither in non-OSA group. And also, it was seen that the dynamics of systolic arterial pressure in SOS group and the non-OSA group, that was different for genuine intervention, and between the group which had a placebo, and it was seen in the median decrease of systolic pressure, and in the group of patients without OSA, based on daily monitoring, there were no difference found. Sub-analysis of this study demonstrated that in the group of patients with obstructive sleep apnea under non-invasive ventilation to one-tier ventilation had a trend towards difference in systolic pressure 6 months after, both inside the group and who received the active treatment, who had the active surgery, and also between the placebo group and compared to the group, for example, when Cpap therapy was added for patients with resistant arterial hypertension, but who had placebo, well, did not change into group measurements, but there were differences between the group, that the genuine innervation had more control over arterial hypertension compared to just placebo. And when we analyze the frequency of stabilization of the daily profile with the help of systolic pressure over 24 hours, the normal denervation did not cause any significant. There's a trend towards increase in frequency of the profile monitoring, and also the surgery group had more frequent stabilization of the profile. And when we split all of the patients who had stabilization of their daily profile, there were no significant difference in mean arterial pressure, systolic pressure, and also after assessment in the group of patients with the OSA. That is why the Russian clinical guidelines of cardiological society say that degeneration of kidney arteries is not recommended for treatment of arterial hypertension routinely before there are more data available about efficacy and safety, though as for breathing correction and additional effect on the level of arterial pressure, well, the scientists, they were working on that for a long time. So this is the meta-analysis of 16 studies with the Cpap therapy for obstructive sleep apnea without hypertension. We see that in order to assess the decrease, so the daily monitoring was used, and or it was assessed at the office, and systolic arterial pressure. It was by 2 for millimeters, and it was less than 2 for diastolic. But these are not hypertension patients. Earlier works dated 2015 demonstrated that Cpap therapy had an impact on daily average, and the meta-analysis includes 7 randomized clinical trials. It was also demonstrated the efficient impact on mean systolic and diastolic pressure, which was for systolic 2.3 millimeters, and diastolic was decreased practically by 2. But look at compliance. It was from 4.5 to 6 hours, and at night was done from 1 to 6 months. And to demonstrate that compliance in Cpap treatment for assessment of efficacy on arterial pressure is a very important component. And I also mentioned the results of one of the results which demonstrated that as the comparison, so the ventilation for 5 to 8 hours, if we take this criteria, and there is more decrease for all of the monitoring parameter in patients who had no, the compliance from over 5 hours during the day. According to more recent data published this year, meta-analysis of 8 studies demonstrates sharper decrease in arterial pressure parameters during the day in Cpap therapy, but this influence was mostly due to during the day. If we look at Cpap influence, that was no statistically significant, and it was mostly due to influence on the night hours, and compliance to Cpap only in 3 out of 8 studies, adherence was over 4 hours, and the rest 5 had the mean use less than 4 hours, and it was from 8 to 24 months. If all of the 8 studies would include compliance exceeding 5 hours, more probably the decrease of systolic and diastolic pressure would be even more pronounced. I mean, the mean numbers. And one of the studies demonstrated direct correlation between the numbers of arterial hypertension based on daily monitoring, and this correlation with the length of Cpap therapy. And so it turns out that all of our efforts to correct the arterial numbers and also to decrease the negative impact of obstructive sleep apnea, well, our therapy should be more aggressive in all discussions. Was always concerned about one thing: if for clinical trials, well, of the pills that we use to decrease arterial pressure, they indicate clearly that the patients should not be included. Those who have negative experience with low adherence for hypertension treatment, they should not be included, they should be excluded. And still, we get a situation when 3 hours compliance patients, I just don't mean the arterial hypertension patients, people who deal with the sleep apnea, they understand that Surfage study, this is what I mean. The average, the mean was 3.5 hours, that of compliance, and so we accept those results, and we just take actions based on them. I think we need to eliminate and just nullify all of those results. And the best tool is a rational and timely treatment. I hope that I managed to prove that in my presentation. Thank you for your attention. Thank you very much. The last slide was a little bit scary. Yes, no, that is not scary. I don't do that to my patients so that people do not fall asleep at the end of our symposium. I just needed to wake everybody up so that they at least remember this image. Now we are going to move on with our agenda, and we have some time left. We are going to discuss the questions, or we'll have a discussion if there are questions, so maybe we will have the Q&A session. Can you see my presentation? Dear colleagues, we continue our work now. I would like to give floor to the next speaker, and I would like to emphasize the key points for a general practitioner and internal medicine doctor to should take into account in his practical work and patient management. I would like to just remind you that sleep is the foundation of life of any human being or living being. If we will just look at the medical Sapio officinalis. So its structure of sleep is similar to humans. It sleeps less, 3-4 hours a day, and this creature also sleeps if we look at the flies, these flies that appear, the fruit fly, or even if we look at the worm or hydra. If you remember, in biology manuals we had such a creature called hydra, and they do not even have brain or a nervous system, and still they had this condition. And sleep is a foundation of any living being. It's fundamental, and it provides for life quality, and it also maintains our life. And sleep is not the time that we spend in bed. This is a unique condition, and this is something that we should allocate a lot of time to study. Talking about proper sleep in clinical practice, there is decrease in sympathetic activity, increase of parasympathetic activity, decrease of variability, a decrease of heart rate, and sleep condition is subject to multiple impairments, and about 80 types of them are in international publications. So one of them is obstructive sleep apnea, and here we see a person. Yes, there is increased pressure. He's not very active, and we may see that upper part. This is apnea, and this is the 3-minute gap, and there is respiratory stoppage for 3 minutes, and then 3 respiratory movements, and then another time there is apnea, and there is a decrease of oxygen down to 50 and more, and also 90 and less for COVID. This is the indication for intensive care, and in some patients it can be present every night, and it also may have impact on hypertension, the obstructive sleep apnea. So our colleague already spoke about that. Starting from 2014, we see that the European Association for Arterial Hypertension introduced its guidelines the direct correlation between obstructive sleep apnea and arterial hypertension, and which is increasing the number of cases of arterial hypertension during night. And widely discussed topic is the length of sleep and cardiovascular diseases. And in one of the studies, the all-cause mortality is decreasing for ischemic disease, for strokes, and also it is increasing while sleep. We say that it is about health, and increased sleep also is related to chronic inflammation and chronic diseases, other comorbidities. That's why the length of pathological sleep can increase all-cause mortality and also stroke prevalence. And one of the recent studies of 2021 published in Your Heart, they used the data of over 400,000 people in UK from the biobank to assess correlation between sleep length, and they did Mendelian randomization, and which gives us the course and origin correlation between the predictors and factors and outcomes. And they had 78 SNPs, one nucleotide sequence associated with the sleep duration, and it was demonstrated during linear analysis that 1 extra sleep hour decreases prevalence by 19% of hypertension, pulmonary embolism by 49%, chronic ischemic heart disease, arterial by 27, and by 22 arterial fibrillation. And according to nonlinear MR analysis, shortening of sleep, which was associated to 22 SNPs, increases the risk of arterial hypertension, pulmonary embolism, and myocardial infarction and coronary artery disease. And here we are talking about sleep duration. One nucleotide sequence is changed here, and this is the direct evidence of sleep duration on progression of diseases. And atrial fibrillation is also associated with apnoea. And we see that one of our patients of 27, we see lots of apnoea with hypoxia, and there was disruption of the rhythm, and also caused atrial fibrillation. It was stopped at the level of delta wave, so that was the deepest sleep, which is the most restorative moment, because there is the maximum decrease of heart rate, tension, and sympathetic activity as well. That's why the final stage can restore many pathological processes. Starting from 2010, the Russian Cardiological Society and European Cardiological Study mentioned in its guidelines that sleep apnea may be a pathophysiological factor and should be tracked in the population. Those who have been in this topic for a long time, and there was a safe study which demonstrated that sleep apnea cardiovascular points, and there is no change of the endpoints. We see that the mortality practically is the same as 84 weeks, and we say that we need to use Cpap therapy with increased tension, but the endpoints did not change. Why? Because when we went deeper to assessment of the criteria, inclusion criteria, well, to be honest, we were shocked because the saturation index was introduced. That was the very moderate apnoea. The saturation may be due to other reasons, and as for duration of Cpap therapy, we achieved very good results to decrease tension with the Cpap, with the length exceeding over 5.8 of hour, and the average compliance was 3.7. That's why we need to interpret the results very carefully. This is the example of the man. So here the saturation is okay, and we see the saturation, and till 6 a.m. We see decrease in saturation, and then it gets to to a different range, and he's not considered to be a sick person. He is not aware of his health condition. We understand if we are not treating the person now, then in 5 or 10 years, it will be a refractory hypertension, infarction, or stroke. He may die during sleep. That's why it is important to start treatment early and efficiently, not to get to the numbers and conditions when it's very difficult to intervene with the treatment. We have to use different methods. Hypoxia, it is intermittent, unlike the constant one. It has lots of consequences: increase of sympathetic activity and the increase of the processes, oncological processes, and also in many studies there is direct relation between sleep apnea and cancer diseases. That's why intermittent hypoxia at night is very important in terms of understanding of pathogenesis of many diseases. And from the point of view of treatment, one of the mechanisms of hypoxia, it decreases the functions of the canals, which the decrease of HRG is the main reason of enlarged QT, which causes arrhythmia and sudden death, and hypoxia causes expression of calpain, and calpain is released to extracellular environment. And now I would like to speak not only about apnea, but about insomnia. One of the most important studies in sleep 2010, mortality among men. With the sleep duration of less than 6 hours was 4 times high compared to group without insomnia. In presence of diabetes and or arterial hypertension, it increased by 7 times, and it was not seen in women. Insomnia may have a major negative impact on the health, and also there is interesting study published in Nature 2019. It was demonstrated that in sleep deprivation and insomnia there is decrease of thyroxine. This is the peptide which provides for awakening, and these peptides decrease for down to 0, and at the same time one of the functions of the peptide is to retain excessive blood formation at bone marrow level, and there is autoimmune reaction. The macrophages start to quickly get to blood flow, and also they appear with the plagues are, because even children may have them, and this is the autoimmune reaction when there are impairments and deprivation of sleep. Of course, it may trigger ischemic heart disease, stroke, and infarction, especially in morning hours. While excessive sleepiness during day is very important, and we published the results in 2016, 40.9% of respondents, and that was over 5,000 people, mentioned excessive sleepiness, and the main group were young people aged from 20 to 35, and the main cause was sleep deprivation. So they did it by themselves because of social engagement, because of work. They were watching TV, using PCs, and so on. Chronic sleep deprivation and lack of sleep is more and more frequent. And also we demonstrated that during 3 years there is statistically significant increase of excessive sleepiness in the population. Year on year, sleep deprivation disorders are becoming increasingly important. An important aspect for clinical practice is the use of the different medications, and we see that if we use sleeping pills and somnifacents, so also benzodiazepines are increasing risk, or antidepressants which are non-benzodiazepine. Can you imagine when you treat a patient, you decrease the hypertension and then you use hyperlipidemic and so on, you decrease the risk by 20, 30, 40% in line with the modern studies, but the patient has sleep issues and neurologist or GP prescribed some sleeping pills for long-term benzodiazepine, and you increase mortality by hundreds of percent, and you just completely eliminate the benefits of CVD treatment. And also how to assess the correlation between different sleep disorders and symptoms which are associated with sleep. And the patients were from 18 to 39, BMI from 18 to 25. The clinical characteristics of the sampling. So we had 2,094 people, and mostly females, mean age 25.8, and BMI 22 and we assessed the influence and correlation between different symptoms which characterize the day sleepiness and OSA, and we saw that if there is apnoea, if you have apnoea, so the snoring is more frequent. The same is true for sleepiness and apnoea. And even for a normal BMI group, we see correlation between sleep impairment and symptoms associated with sleep and arterial hypertension. And so we did cluster analysis, and we have 3 clusters, and the most severe is the third one. Prevalence of arterial hypertension is 46.1%, which was statistically significant. It's more compared to the first and the second class. And also the relative score of the responses required to be assessed to understand whether it's significantly important or not. And in case of more snoring and more apnoea, there is an increase of arterial hypertension prevalence. And they characterize worsening of the situation, and the symptoms become more severe. At the same time, in presence of depression and anxiety, there is decrease of prevalence of hypertension. It is in line with the data of the studies on anxiety and depression. The prevalence among these patients is smaller. So the chances of hypertension in patients aged from 18 to 39 with normal BMI increases by 2 and more folds in presence of different types of sleep deviations and symptoms associated with the sleep. And we believe that possibly this is one of the primary causes of arterial or social hypertension, or this is the main factor which triggers refractory arterial hypertension and refractory in particular. And when the patient is 40 and plus, when he just contacts the clinic, the doctor, probably this is the time when we need to pay attention to the quality of sleep in our young patients to avoid development of arterial hypertension. And dear colleagues, let me finish my presentation by saying that we practically have no time left, but if the organizers will allow us to have the final word, so we will do that. The project that we recently launched, somnolog.ru, those who are interested in that, well, we also have questionnaires available on our website. We are ready to do joint clinical scientific work and so on. So, Yuri, if you are still with us, you have the final word. So he left. Dear colleagues, thank you for your attention. There is a question. Yes, I'm here. So Yuri, you have the final word. Thank you very much, Alexander. Thank you for invitation. I think we will continue our work, and just I think today we had a great symposium. Thank you. I would like to thank all of the participants. Thank you, dear colleagues. See you. Goodbye. it can speak about the following. Each lab test we need to clinically interpret. Increased prothrombin time may speak about K vitamin deficiency, about warfarin intake, liver disease on DVS syndrome. In INR, international normalized ratio, less than 2, hypercoagulation, risk of thrombosis less than 5, it's hypercoagulation and risks of bleeding. That's clear about that. It's quite simple. Of course, we are talking about the control over warfarin. INR should be around 3. And as for fibrinogen, you see the note from 2 to 4. GL increased in fibrinogen might speak about any infection, myocardial infarction, brain stroke, hypothyrosis, amyloidosis, cancer. Decreased fibrinogen may be a symptom of a disseminated syndrome, coagulation syndrome, deficit of BC anabolics, and also omega-3 may decrease it. And without giving the details, so omega-3 may cause bleeding. And also I should mention the DIC here. What happens with didymer, fibrinogen, is dissolved by thrombin. Then it turns to fibrin polymer under factor 13A. It is dissolved by plasmin, which gives us degradation product of fibrin called didymer and didymer level. It gives information about the following. Its increase speaks about thrombosis. As we are in pandemic of COVID-19, you all know that didymer is also taken as a test, and these are not the current characteristics. If you look at all of the tests related to thrombo formation, we can do platelet count and fibrinogen and didymer, and the rest of indicators are not so important. We do them once. I think we just need to do that over time. Together with coagulation indicators, we need to also assess peripheric blood. That's banal, but I would like to remind that platelet control should be in place if we have thrombocytosis over 320 per 10 and 20 in 1 ml. So this is increased thrombotic risk. And we need to enhance antithrombotic treatment, and the opposite situation if it's less than 160 by 10 in 9th. So we need to think that antithrombotic agents may have some side effects like aspirin, and also we could think about increase the dosage. Critical is 50 by 10 in 9th. After this, we need to just cancel any substance which may further affect the thrombocyte level. As for the red blood, so we need to have a look at erythrocytes and hemoglobin. If there is a decrease, there is no follow-up, so there should be bleeding. We need to look for this source. Afterwards, we are going to use antithrombotics, anticoagulants, of course. We could provoke normal bleeding, but if they are decreasing today, but in a couple of days, so the hemoglobin level is going down, red blood cells is going down, and we need to look for the source of bleeding and think about canceling antithrombotics. Of course, these are anticoagulants. Direct ones, heparin, non-fractioned, low molecular heparines, fondaparinux, bivalirudin, Indirect ones are the oral anticoagulants warfarin, apixaban, dabigatran, rivaroxaban, and acetylic acids, inhibitors P2Y12, clopidogrel, prasugrel, ticagrelor, and blockators of glycoprotein 2B3 platelet. So this is always antiplatelet therapy. Also, we need to understand which is the group of medications which have a general name of antithrombotics. Well, antiaggregants can be used, antiplatelets, acetylic acids, clopidogrel, ticagrelor, or both. In some cases, we know in which cases. When we have double antiplatelet therapy, low molecular therapy fondaparinux influences antithrombin 3, decreases activity of factor 10A, and impacts thrombus. Apixaban, rivaroxaban orally also impact 10A factor. The bigatron has different mechanism. Talking about thrombin formation, it impacts thrombin, and warfarin has different mechanism. It impacts the synthesis of vitamin K-dependent clotting factors 10 and 7, so it has a varied action. I would like to clarify the situation with heparins. This is an important point when we say which drug should be used. So it impacts antithrombin 3, decreased activity of factor 10A, and decrease further formation of thrombus. A little bit more efficient is enoxaparin, and the most powerful binder is factor 10A. As for COVID-19, you see it appeared quite unexpectedly. It popped up like on my screen. Thrombotic diathesis, this is the situation which is present before and after COVID. So what we should pay attention, and we'll have here as different patient cases. So we have thrombosis in different systems, in venous or arterial system, and of course why it's so difficult. We need to control the situation, and we need to use the antithrombotics, well, in particular anticoagulants. To finish my presentation, I would like to say that today we will consider the practical questions around intracardial thrombosis, antithrombotics for diabetes mellitus with 2 clinical cases, and thrombotic complications after COVID-19. Thank you for your attention. I finished my presentation. I would like to give floor to Galeva Zulfiya, who will present clinical cases of intracardiac thrombosis. Zulfiya, you have the floor. Good afternoon, dear colleagues. I hope that you may see me and you may hear me. Yes, dear colleagues, I'll try to speak about this important topic in terms of clinical cases and some theoretical data which can be applicable for such patients who have intracardiac thrombosis. I'm going to start from a clinical case, male, 1956 year born, and he got sick in the year 2000. He had very moderate pain in the chest. It did not limit his physical abilities and activity. He did not visit any doctor, no treatment at that time. But after 15 years, he had dilatation cardiomyopathy diagnosed. What happens next? So he is admitted to hospital to compensate chronic cardiac insufficiency. And so you see the percentages, and starting from 2018, he has hypertension. In 2016, he had coronary angiography and stenosis of the up to 13% was found. In December, he comes to our clinic because since September, he has a growing shortness of breath, and starting from December, he had decompensation and previously had the descending artery issues, and then the big circle is involved as well. From bad habits, he smokes for a long time and a lot. We see that he's been smoking for over 30 years. He rejects abuse of alcohol when he was admitted, and of December beginning January 2020, he has inspiratory shortness of breath. So when he's in bed and in minor physical activity, he has shortness of breath, breast behind the chest, feeling of pressure on the maximum pressure to 150 to 80. He is adapted to 110 to 80, and the edema to the upper third of the shank, and the patient noticed that his stomach increased, and also he has ascites, and his condition was moderate. In the lungs, there were no issues, so frequency 18, heart rate 97, so HR of 85 to 60, and unfortunately he had edema. We do echocardiography. And EF, ejection fraction, is decreased 18%, and the left ventricle is 7.1 with the index 3.4, and the local contractivity of the left ventricle, we see diffuse hyperkinesia in the walls, and there is mitral and transcubital regurgitations, and the apex of the left ventricle had a thrombus 3 to 1 centimeter with slow motion, and we are not talking about any thrombosis. We do ECG, practically the same data, no increase in EF, ejection fraction. LV, left ventricle, remains enhanced, and the lung artery is a little bit affected. What are the thrombus? So the apex of the left ventricle, and in the following videos you may see other thrombus, so another 2 of them, and in the right you may see that better the thrombus is moving, which is 1 to 1. When he was released, we see comparison on the sizes, ejection fraction at admission and when he was released, and we do not see changes in EF. It's negative, though it's not significant, and there is a decrease of pressure in the lung artery, and in our conclusion we may read and see in the video that he has a thrombus. It's 1 thrombus left, but unfortunately he has a floating fragment 0.5 to 0.5. And when he was released, the following diagnosis was given: dilatation cardiomyopathy, ejection fraction left ventricle 18%, arterial sclerosis of coronary arteries, stenosis of the middle segment 30%, rear extrasystolus, supraventricle and ventricle, hypertension second stage, atherosclerosis brachiocephalary arteries, and chronic heart insufficiency, the second B, and hydrotrax, and thrombus in the left ventricle. He also has comorbidity, chronic obstructive lung disease, and we also worked with this disease as well. First time diagnosed, second type diabetes mellitus, and also include mixed nephropathy C2. And yes, the 6-minute walking test, and it's around the third functional class. And the warfarin dosage was selected in the hospital, which is the indication for left ventricle thrombus from 2 to 3 INR was achieved. And now we see that tablet with the warfarin dosage adaptation and with INR change on warfarin. So what was recommended warfarin under ivaprodine captopril, our patient could not have the good dosage of inhibitors because he had hypertension, so it got stabilized. Toracimid, eplerenol, beta blockers were not prescribed. He had a Hubble exacerbation, and ACE we did not prescribe, and we hope that he'll have remission and that he would stop smoking. And bisoprolol was recommended small dosage with the heart rate and bronchial control as well. After stabilization, which should be at least 10 to 70, it was also recommended to use sartanibulin, starting from a small dosage, 25 milligrams, and then control the hypertension. And also the ACE should have been cancelled before the first dosage of sapapril-sartan. Why we did not recommend hypolipidemics to this patient? I would like to draw your attention to this. And let us look at our clinical guidelines for patients with chronic heart failure. There is such information. If there are no additional indications for statins for treatment of chronic heart failure, if our patient has low EF, less than 40, this is our patient. Etiology is not important, so it's not recommended. And the benefits of statins in CHF patients is not proven. And you may see the data about patients with severe chronic heart failure, ischemic, non-ischemic, and low ejection fractions who had standard treatment for CHA. There was no incremental positive impact on prognosis from statins. After release, he has satisfactory condition, no increase in shortness of breath, but during his visit to the clinic, it was decided that he needs to be admitted to hospital to further elaborate on his tactics. So he has chest pain during physical activity, and decompensation as is not present. Then he's lifting his head when he sleeps, and the maximum pressure 150 to 80. And frequency is not of breathing, and rail crackles present in the lungs. So echocardiography in dynamics. And as we may see, no significant improvement, though 24 is the EF. Yes, compared to what he had, there is significant improvement because he complied with the treatment. and the pressure was decreased to 40 from 48 in the lung artery. There is still diffuse hypokinesia. What happens with this thrombus of our patient? Only one thrombus found, 3 to 2 centimeters, 3 by 2. No floating element. Yes, we have positive changes. The patient complied with our recommendation. Lung X-ray. There are no infiltrates, no hydrothorax, no liquid in abdominal, and so sinusoid, no hyperemia of stators, and ventricular systoles, ventricular tachycardia, and supraventricular extrasystoles systoles. Well, let us once again look at clinical guidelines on patients with the chronic heart failure. Yes, our patient is better, but we need to think about his future. Such patients, like our patients, we had non-ischemic systolic dysfunctions of left ventricle, ejection fraction less than 35, and class 2-3. Cardioverter defibrillators are recommended. And provided the optimal medication therapy, survival prognosis 1 year to decrease the sudden death risk and all-cause mortality. Yes, we just explained that. We also said that there is such a method, and we explained that he needs that, but the patient rejects surgery. We talk about his diagnosis: dilatation cardiomyopathy, ejection fraction better 24, hypertension third stage, thrombus in LV, and lung tension, diabetes type 2, glycated hemoglobin and hemoglobin, no exacerbation. And also the chronic obstructive lung disease is still there. About treatment of our patients, we recommend that. And valsartan, bisoprolol, small dosage, valsartan, sacubitril, so that's a good start. Warfarin was selected, ivabrin, spironolactone, toracimid. When he was released, the frequent so 16, heart rate 78, 120 to 70, that was the blood pressure. And after 6 months, more or less, our patient himself comes to our clinic, to admission department. So he has edemas of lower limbs, shortness of breath, and less tolerance in case of physical activity. That was in February 2021. That was before August, the last hospital stay, and he felt okay. But what happened? The patient decided that he is completely healthy, and he did not take the medication after he was released in hospital. So the rattling in the lungs, and of course we do troponin test. Troponin test is an NT-proBNP 16,000. We have up to 120. It's by 25. It's by 100 folds higher than the norm. Blood assay, that was quite okay. And of course, we have different indicators: ALT decreasing, lipid profile, urine is increased, and lipids of high density. As for electrolytes, no comments. The filtration speed remains at the same level. As for ECG, we see ejection fraction 119, and also 54. This is the pressure in the lung artery hyperkinesia. So it's of diffuse type. So let us look at the thrombus. Dear colleagues, we do not see we have worsening in our patient. I will show in the how it was developing. And in the lower limb, so there were no thrombus, and there were no infiltrates in the lungs, no hydrothorax, and no liquid in the abdominal. In Holter, we see the same deviations, arrhythmia. So we have extra systoles. So we also have sinatrial extrasystoles, supraventricular tachycardia, extrasystoles, ventricle, and ST is lower. In the ECG, so the rhythm is sinus, and the negative T in 1 AVL V6, a low amplitude R V1 V4, depression of T down to 0.5 mm in V6. Ejection fraction increased to 22, diffuse hyperkinesis stays. And let us look what happens with the thrombus. This is only one thrombus close to the apex. And here we may see that from the thrombus there is a so-called floating element. It is long. It's almost 2.5 centimeters. When the patient was released, we once again have dilatation cardiomyopathy, ejection fraction 21. The thrombus in the left ventricles stay, one of them with a floating borderline, mitral insufficiency, transcubital insufficiency, and CHF, and also arterial hypertension. As for comorbidities, we corrected them. All of them are in the diagnosis with target levels, talking about diabetes. And we might say that our patient was indicated with cardiovertebral fibrillator. He has the risk of ventricular arrhythmia because of the low ejection fraction, and we also recommended coronography to assess the coronary condition. So, but the patient rejected any interventions. Amiodarone was not prescribed to correct arrhythmia because the of QT interval. 6-minute walk test. Yes, the condition is positive, and also there is no orthopnoea, so lessening of edema, shortness of breath, no issues with electrolytes, and INR from 2 to 3, and the warfarin was corrected, and the size of thrombus decreased. As for treatment of our patient, so we are increasing the dosage of valsartan or bisoprolol, or we also added dapagliflozin, and the warfarin. So this is the maximum medication for this clinical situation. And also we had such a phrase in the conclusion that he should take the medication regularly to once again focus and draw the attention of the patient that his compliance means that he must do that. Without the medication, he will come back to hospital. He will be in the risk group for thrombus formation as well. Dear colleagues, we spoke about thrombus of the left ventricle, and there are new data which say that on top of warfarin, yes, this is the golden standard for this situation. And we need to use the new, the NOACs, the new oral anticoagulant. And we see the intraventricular thrombosis here, the cascades of coagulation that Albert spoke about. We can interfere into this cascade, influencing different coagulation factors, and we can use rivaroxaban, edoxaban, apixaban, and dabigatran. Of course, we need big randomized studies. Of course, it's only ongoing. And I would like to show one of the small studies. One group of patients had warfarin, the second group had in new oral anticoagulants. And these are the columns in black, what happened 24 hours. In 24 hours with the thrombus, so whether it was resolved, and with the use of the NOACs, they are winning for resolution of thrombus compared to warfarin. As for safety, for warfarin and the NOAC, so that was also a comparison. So the frequency of systemic thromboembolias was lower for the new anticoagulants, and the bleeding rate was also lower in this group of NOACs. This is the data which appears now, may just make the researchers do big randomized trials and big studies, and in the future we will have new indications for, as the indication, the left ventricle thrombus. And also I would like to draw your attention to our guidelines for patients with CHF with the quality criteria. So these are the clinical recommendations for 2020. So these are the quality criteria for us to be checked. Will be checked by the expert, now those who just monitor medical histories, and we need to also deliver those quality criteria. If we go through those points, we did everything for the patient. And in terms of these criteria of quality, we can just tick all of the boxes, and we may say that we did everything in line with clinical guidelines summarized in my clinical case. And with anticoagulants therapy, he had positive dynamics in February 2021, decrease of thrombus in terms of size and volume. But because of stoppage of therapy in August 2021, he had the compensation of chronic heart failure and the new thrombus in the left ventricle appeared. The prognosis is unfavorable because of low compliance and rejection of cardioverter defibrillator. Thank you for your attention. That's the end of my presentation. Thank you. Zulfiya, I would like to draw attention to important practical details and the thrombus in the left ventricle doesn't have clinical manifestations or symptoms. We need to just find it with the ultrasound methods, and the echocardiography is the most simple. And the second, about cardioverter defibrillator. Of course, this is an aligned body, so, and also this is a life-saving surgery. And I would like to draw attention to this clinical case. The patient stopped treatment, stopped the medication, and it caused decompensation, severe decompensation, because he was in severe case. And also, adjustment of warfarin dosage took twice as much. If it took 7 days in the first place, so the second time it took 14 days because of decompensation stasis in the liver, bad liver function. The thrombosis of left ventricle, we need to find them, and we need to treat them properly. And the most powerful is warfarin, talking about oral medication. Whether we'll be able to help with the new oral anticoagulants to just remove the thrombus and decrease their size. And it's robotic treatment in diabetes. Hello, good afternoon, dear colleagues. I hope that you may hear and me. Antithrombotic treatment for diabetes mellitus. 90% of diabetes 2 type patients have obesity. The adipose tissue produces lots of cytokines, active oxygens, and it causes resistance to insulin and causing hyperglycemia, and also it causes diabetic cardiomyopathy. We know that diabetic patients have lots of low density lipoproteins, atherogenic particles, and with hyperglycemia, they have diastolic dysfunction, endothelial dysfunctions, and the platelet activity increases, which increases antithrombotic risks, diabetes, endothelial dysfunction, and there is a decrease of production of the molecules which prevents activation of thrombocytes. Hyperglycemia impacts the thrombocytes, and on the membrane of platelet there is an increase in receptors which activate the thrombocytes, and diabetic patients have higher concentration of thrombin and fibrinogen, which gives formation of fibrinous net, which is not susceptible to fibrinolysis, and diabetic patients in thrombus have high number of proteins which prevent fibrinolysis. And what we have in patients with activated thrombocytes, dense thrombus, hyperfibrinolysis, increased risk of atherothrombosis. Our goal is to prevent this condition, means that we need to prevent atherothrombosis. And what do? We do primary prevention if the patient doesn't have a cardiovascular disease, and antiplatelet monotherapy. As for secondary prophylaxis, there are two ways. Antiplatelet monotherapy, double antiplatelets, or combination of antiplatelets with anticoagulants. And then, to understand better what we should choose for specific patient, I will show my clinical case. First case, male, 49 years old. He was admitted to hospital. Well, his medical record in August 2021, he had fits of non-intensive pressuring pain in the chest without any relation to physical activity. And then on the next day, they were irradiating to the left arm, more intense in the evening. He called the ambulance. Arterial AP 30 to 80, no signs of ischemia, acute coronary syndrome without elevated ST, and in outpatient clinic, that was the prescription. He was with the hospital in 2018. He had hypertension. He had high tension. Then he controlled it. Then diabetes mellitus second type, and the treatment at that time. He's not a smoker, but he has in the family records father's infarctual myocardium at the age of 58, then obesity of the second grade, and 75. This is the heart rate per minute, and his tests in the lab test: troponin twice norm, glucose, glycated hemoglobin, matching the diabetes, lipoprotein 2.4 millimole per liter, echocardiography, and no hypertrophy, and no local deviations in contractibility of the left ventricle. And they did coronary angiography and found a plaque in the lower descending artery. Stenosis is small, only 30%, hemodynamically insignificant. Holter monitoring is done to exclude potential stenocardy, vasospastic stenocardy, ST without change, to exclude comorbidities as a vasogastrinoscopy is done. Only chronic gastritis is found, and atherosclerosis of brachiocephal artery is found with stenosis up to 35%. And there is a load stress test done, stress echocardiography with treadmill, and visualization to find ischemia, myocardial ischemia, local contractility of left ventricle during the stress and post-stress. It has normal contractility, so the test is negative. Let us look at our patient, to which category of cardiovascular risk he may be assigned after the test. He has diabetes type 2, and also he has 3 risk factors: arterial hypertension, obesity, and dyslipidemia. And this patient without cardiovascular diseases goes to high risk group for cardiovascular complications. He has a diagnosis. Acute coronary syndrome is not excluded, and the patient stays with hypertension stage 2, controlled arterial hyperlipidemia, risk 4, very high, target levels of pressure, angiography data, atherosclerosis of brachiocephal arteries, diabetes type 2, and target levels of HbA1c 1C, glycated hemoglobin, and the second rate obesity, second group of obesity, second class. So what are the algorithms for patient management? The patient has diabetes. We need to select antithrombotic treatment, and he has primary prophylaxis. And if he has high risk, so we need to consider assay in low dosage. Yes, that is the medication as antiplatelet acetyl salicylic acid 100 milligrams. Another patient, male, 56 years old. His medical record in September 2019, all of a sudden, he had sharp shooting pain and no irradiation, and called ambulance. AP 165 to 100, ST is elevated in V3 and negative in the first and AVL segment, and preliminary diagnosis acute coronary syndrome with elevated ST. Treatment is prescribed and the patient is admitted to hospital. In his medical record 10 years ago, for the first time, he was diagnosed with hypertension with very high AP, but according to the patient, he did not control, he did not take medication. In 2011 and 12, 2 times, he had acute brain accident, brain events. In the same year, he was diagnosed with the diabetes type 2 after acute cerebrovascular event. And that was in 2015. And in 2015, carotid endarterectomy was done to the left and right. And then coronary bypass. In 2017, atherosclerosis of lower limbs is added with occlusion of arteries. Stenosis of the left kidney artery up to 70%. He's a smoker, but no family anamnesis, no family history. Well, that's a very different compared to the first one. He has multiple cerebral damage. He has infarction, acute cerebral vascular event or accident. And these are the vessels of the brain, kidney, artery, that of the limbs, and they are AP low, higher, and heart rate and lab test result. When he was admitted, twice troponin was tested. It's in the normal range. Increased glucose and glycated hemoglobin, and the lipidogram, cholesterol lipoproteins of low density is increased, and he has NT-proBNP increased, which speaks about heart insufficiency. Let us look at echocardiography. Hypertrophy of the left ventricle. Ejection fraction of the left ventricle is normal. And to conclude, we see that hyperkinetic zones in this patient are absent. Coronary angiography is performed. Multiple stenosis are found, but we may see that the passes provide for blood flow, which was installed previously. This is the scheme of coronary angiography. You may see here that the descending artery is the right artery. There are plaques, but the also the circumflex artery. There are no stenosis, they are patent, and no severe thrombosis with further cantiler, and chronic gastritis, and prolapse, hernia, second type, and Holter and ST and T, no changes, and his arterial pressure decreased with treatment in ECG compared to admission, remains unchanged. Elevated ST in V1 to V3 and negative T, no changes. Atypical pain syndrome, troponin in normal range, and coronary angiography excludes the acute coronary syndrome, and also ischemic heart disease, stable stenocardia, a functional class 2, coronary bypass, and also coronary arteries of 3 vessels are damaged, myocardial muscle bridge, hypertension third grade. He has diabetes type 2, and glycated hemoglobin should be less than 7.5. CHF, residual period after ischemic accidents in the pole, and also atherosclerosis cephalic arteries, lower limbs, kidney, artery, chronic gastritis, etc., and the algorithm of this patient management for antithrombotic treatment. The patient had infarction, but acute coronary syndrome was not confirmed. That's why we need to consider long-term treatment. What is advised? SA, clopidogrel as monotherapy, but if the patient has low bleeding risk and high risk of thrombotic complications, now we should consider enhancement of antithrombotic treatment. What is advised to ESA? Add rivaroxaban or ESA plus clopidogrel. Let us have a look once again at our patient. He has stable ischemia. What else we should ask? High ischemic thrombotic risk. Is it present? He has multiple arteries lesioned. He has diabetes. He has infarction in record, and also peripheral arteries have ischemic lesions, so he has a high ischemic and thrombotic risk for sure. Then the next question, whether the patient has high bleeding risk. What can it be? Recent bleedings, intracranial bleedings, pathologies of GIT, liver insufficient, hemorrhagic diathesis, old age, and chronic kidney disease, which requires glomerular speed less than 15 per minute. Our patient does not have that. That's why we need to enhance the antithrombotic therapy. And what we can find in scientific literature, there is data about that, what to do with such patients. The patient after acute coronary syndrome with a high ischemic risk. But our patient had infarction, and now he has high ischemic risk. He has a low bleeding risk, and we should ask if the patient has double platelets. So he recently had the acute coronary syndrome. He's taken for 12 months the double antiplatelets, and then he should go to double platelet therapy with the ESA plus ticagrelol 60 milligrams twice a day. But our patient just stopped double treatment long ago, and he had infarction more than 2 years ago. It was 6 years ago. That's why what we choose acetyl salicylic acid, ESA, rivaroxaban, and in 2.5 milligrams twice a day. And the same combination can be used if the patient has stroke, previous stroke, coronary bypass, and several vessels are damaged, and low filtration, several vascular pools are lesions, and the ejection fraction of left ventricle, and high vascular class of chronic heart failure. If you find such factors in the patient, he will stay on with the monotherapy of ESA. Let us look at the treatment. Ivermectin, metoprolol, ramipril, amlodipine, atorvastatin, nitroglycerin in case of pain, and ESA in enhancement, rivaroxaban 2.5 twice a day. Empagliflozin was prescribed to treat diabetes, and patient management. Well, atrial fibrillation patients, well, the management is no different for a patient compared to patients with the sinus rhythm, and peripheric artery disease patients. No symptoms, it's primary prevention. If there are symptoms, clopidogrel, monotherapy. And if it's multiple vessels, ESA plus rivaroxaban, 2.5 milligrams twice a day. And to summarize, I would like to say that diabetes type 2 is characterized with increased risk of thrombotic complication, which requires adequate selection of antiplatelet treatment. Thank you for your attention. Thank you very much, Larissa. So, 2 patients, 2 men. And there is diabetes and hypertension, and the second patient has diabetes and hypertension. Of course, this is a multifocal atherosclerosis, very enhanced. All of the complications. This differentiated approach should simplify our life as doctors, and such treatment will also improve the prognosis of the patient who has a combination of diabetes and CVD. Thank you very much. Now we have the final presentation. Well, about COVID-19 hot topic, thrombotic treatment. Gazelle, you have the floor. Just so we are waiting for the presentation. I would like to open the question in the chat. So the question about antiplatelets and anticoagulants, if the patient is okay after COVID. Well, just talking about COVID and antithrombotic treatment, if everything is fine, So we should not use neither antiplatelets or anticoagulants because of absence of indications. And of course, depending on the progression of COVID, the hospital, but given the fact that everything was fine with the patient, then probably antithrombotic treatment should not be used. I said Didymir is okay. Yes, we may see your presentation. That is the beginning of the presentation. We may start the presentation at least like that. But you may see that the presentation, yes, we may hear the presentation, but not on the full screen. Let us continue. Good afternoon, dear colleagues. I will speak about coronavirus, and first of all, I would like to say the following. Also, I would like to say how many patients have coronavirus. 31 million people, 4 million deaths, over 4 million deaths, and also lots of vaccines, millions of vaccines used. Talking about Russian data, so the situation is quite complicated. On September 25, very recently, the incidence rate, according to John Hopkins, were over 21,000 people. This is the official data for our country, and you may see in the middle the number of deaths, but the slides are not changing. So we can see the presentation, and we may also see that the number of vaccinations is so the vaccination rate in our country is dramatically bad. Well, over to the topic of my presentation. And as for thrombotic complications in case of COVID, up to 16% who were admitted with COVID have thrombotic complications, and the lung thromboembolism, deep vein thrombosis, arterial thrombosis, infarction, and strokes, which was found in many COVID patients. Until today, we don't have the complete understanding why there is thrombus formation in COVID infection. There is a direct damage of lung tissues by the coronavirus infection, which further activates thrombocytes and releases fibrins, and there can be systemic infection, which triggers inflammation. Inflammation on the hypercoagulation, which activates the cytokine storm, and the risk group are the patient who are suffering from comorbidities and cardiovascular disease and also lung diseases, diabetes, and other conditions which may worsen prognosis. As a summary release, as a result, fibrin release and deep vein thrombosis, lung thrombosis, arterial thrombosis, strokes, infarctions, and increase of cardiovascular death rates. One of the important lab tests is DDME increase, but in the first place, it's about hemostatic deviations related to coronavirus, because for other conditions which also may be present coronavirus, sepsis-induced coagulopathy or syndrome of dissimulated intravascular coagulation, which is accompanied by also thrombotic coagulopathy, the lab test may be different. In any case, the patients with increased number of DDMER in coronavirus has worsening of prognosis very dramatically. In this slide, you may see the results in Wuhan and other data demonstrating that mortality is directly correlated with increased DDMER. In any case, the patients who are in the hospital and who are considered for management of arterial and venous thrombosis undergo through a system of follow-up and treatment management, which includes clinical symptoms, assessment of severity of coronavirus, thromboembolic complications, and hints about them, and also DDMER is one of the most important indicators. The type of intervention, dosage of medication, further medications, and assessment of patient condition during medication, and also we need to assess efficacy of treatment and how the clinical condition is changing, negative manifestations of anticoagulants such as bleeding. Which slide are you seeing? Okay. Maybe I'll do it this way. And surely, on top of follow-up and management, anticoagulation after release is important. The strategy to select anticoagulants is important, and everything is important. And the duration of anticoagulant treatment as well. We have guidelines on September 21st this year. The temporary methodological recommendations on prevention and treatment of new coronavirus and novel coronavirus infection were issued. This is version 12 with the changes, and the changes on anticoagulants were also introduced among other recommendations. And the recommendations are about the use of anticoagulants in patients who are admitted to hospital. There may be three scenarios. The first one in green, indications for anticoagulant treatment for patients who needed anticoagulants before, atrial fibrillation patients and who had processes of valve. And they consider how to restart anticoagulants after home release. And the second in red, these are signs of deep vein thrombosis and thromboemboli confirm the diagnosis, and low molecular heparins and fraction heparins, and then prevention of thromboembolic complication prevention with the help of oral anticoagulants. And in this chart, this is the recommendations for patients who are in high risk group for thromboembolic complication, who need low molecular heparins and low fraction heparins, and further shift to oral anticoagulants. Similar recommendations are for the patients who are not hospitalized, who are not in the hospital, patients who before coronavirus were taking anticoagulants, and the patients who have coronavirus and they are assessed as moderate or light with increased risk of thrombosis. The list of anticoagulants in the slide from the recommendations, our guidelines, the prevention doses and treatment doses, also for non-fractioned and low fractioned heparin and low molecular weight heparin. The dosages which are used as treatment and prevention of Orex, rivaroxaban 10 milligrams once a day, apixaban 2.5 twice a day, dabigatran 110 milligrams twice a day, or patients with low creatinine level 75 milligrams per day. So the international guidelines for antithrombotic treatment and prevention of such events after a hospital stay. There are lots of opinions. There is no consensus. There are no clinical studies performed until now. They just appear. They just appeared recently, and we need to understand how we can just decrease the risk of thromboembolic complications with more data. And International Society on Thrombosis Hemostasis suggests thromboprophylaxis for patients with high risk of thromboembolic complications up to 30 days, and the American College of Chest Physicians, CHEST, they do not suggest any prevention of thrombotic events. European Society of Cardiology does not supply such information, so you need to just look for such info. Well, based on the recent studies, well, these results are important. Corp19 register with almost 5,000 patients. The register which demonstrates how thromboembolic complications develop in patients after coronavirus. And we see that the frequency of thromboembolic complications, both venous and arterial, is quite high. These are patients which were released from hospital with different types of progression of coronavirus infection, and there was a deep vein thrombosis in 1% of cases, and almost 1% there was lung thromboembolism, and arterial thrombosis were quite frequent as strokes and infarction. And these patients had a multifactorial analysis performed, which helped to identify what components are responsible for increased risk of thromboembolic complications after patient release. And we see that the age, the risk of thromboembolic complications improved d/6 is directly correlated with the thromboembolic complications risk increase after release from hospital. An important component that we pay attention to are anticoagulants. By 46% there is decrease in the risk of thromboembolic complications in patients after a hospital stay. And also we have quite a nice study at European Congress of Cardiologists. This report was done. It's called Michel. They considered rivaroxaban 10 milligrams once a day in patients after release from the hospital. It turned out that these patients had high thromboembolic complication risk. Plus, some patients had high D-dimer, more, which was twofold bigger than the norm. And those who took Eurasian, they had less thromboembolic complication by over 67% after they were released. This indicator was seen more evidently in patients of older group or with normal creatinine clearance, and it was more evident for patients with high D-dimer. Risk assessment for venous thromboemboli improved, which is suggested for assessing the risks of thromboembolic complications after a patient release from hospital, which increase previous venous thrombosis, thrombophilia, paresis of lower limbs, malignization, immobilization over 7 days, stay in ICU, age over 60. Yes, thank you. Well, we just in fact may say that based on the National Health Institute recommendations, the prevention of thrombotic events may be prescribed to patients who in IMPROVE have over 4 points and or they have in modified IMPROVE VTE over 2 score plus D-dimer, which is twice increased, or younger patients with the increased D-dimer or extra risk factors. In this case, Resoxaban is 10 milligrams per day up to 40 days. Pretraxaban, it's not registered in Russia. I would like to present a clinical case, and the patient who was in a temporary infectious hospital in the sanitary department from April 6 to May 19 at our university clinic. And this is the diagnosis that you may see in the slide. The patient was admitted with shortness of breath, headache, and weakness. Patient history, thyroidectomy. She has a resection of the thyroid. She's followed up by a cancer doctor. So there were several tests performed to prove infection, and in biochemical assay, the patient several days after hospital admission had increased D-dimer, a dramatic sharp increase. So at first it was normal. After a couple of days, it exceeded 5 milligrams per ml. Well, after CT of chest was done, we found that firstly, not more than 25 of lung parenchyma was involved, but 4 days after, our patient had progression and the lesions were up to 60%. And also there was worsening of her condition on April 14. She was admitted to ICU. First, in non-invasive ventilation after saturation was 85. She had artificial lung ventilation, infusion therapy, corticosteroid, plasma, cytokine therapy was done, low molecular heparins. And by May 4, she was stabilized. On 15th, she was released from hospital. Well, that's evident that the patient has high thromboembolic complication risk. Let us look at IMPROVE, how many scores she will have and how big are her thromboembolic risks. Old age, she was in ICU and she did not move for more than 7 days, and she has malignization, and D-dimer was 2 times worse than the norm. Resoxaban was recommended 10 milligrams per day, and the duration, well, I think the duration of Resoxaban should be at least 1 month, and these recommendations, we are still waiting for them. Thank you for your attention. Thank you very much, Gadel Maratovich. Of course, the topics related to COVID and thrombotic treatment. Well, here we don't have no clear guidelines, not Russian and no international guidelines. There is option number 12 here, but still there should be some personalized approach. I am just looking at the questions. Should we prescribe anticoagulants 1.5 months after COVID? If the PT is up to 130, Fibrinogen 6. Today we do not recommend to use the prothrombin index. It doesn't give us any information, and Fibrinogen may be impaired due to different reasons. So we should look at the temporary recommendations for follow-up and management of patient after COVID. We need to look at DDMIR level. And it's also important to understand what was the COVID progression in acute stage in this patient. Another question. Can we have 25 to 50 milligrams twice a day for a long time because it decreases the hypertension? 50 milligrams, the instruction says per day. Of course, this is a legitimate instruction. We should not violate that, but I believe as a doctor, we need to act as doctors. If the dose 50 milligrams per day decreases the high AP, so we need to decrease the dosage. It's not in line with the indication. You need to explain the medical record that yet you decreased the dosage because of hypertension. If it persists, of course, you should just cancel this medication because arterial hypertension in patients with chronic heart failure is the sign of bad prognosis. Dear colleagues, our time is up. We finish our symposium. Thank you very much for your attention. Thank you, dear speakers, for your presentation. I wish you all the best. Goodbye.